You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle.
Hi, everyone, and welcome to an episode of the RC Executive Lounge podcast series. As you know, I'm your host, Praveen, and I'm really thrilled you're all here today. Today, I'm personally excited to welcome a guest whose experience and perspective makes this a conversation you do not want to miss. We are thrilled to welcome Garrick J. Stoldt, Chief Financial Officer at St. Peter's Healthcare System in New Brunswick, New Jersey. With over 40 years leading healthcare finance and over 21 years at St. Peter's, Garrick has been instrumental in steering St. Peter's through some of the industry's most pressing challenges, like navigating Medicaid cuts, 340B pricing pressures, rising payer denials, and the strategic integration of AI into financial operations projects. A certified public accountant and a fellow of the Healthcare Financial Management Association, Garrick is widely recognized for his visionary leadership. He was honored as one of NJBiz's leaders in finance in 2021. He continues to shape the field as an adjunct lecturer in healthcare finance at Rutgers University's Bluestein School. Garrick, welcome to the show, and thank you so much for joining us today.
Praveen, thank you very much for having me. I really appreciate it.
Very excited to dive right into the conversation. So let's start with our first topic. There is so much happening in healthcare, finance, and RCM today, more so than ever, because of Agentic AI and all these other newer technologies entering the field. And of course, there are always never-ending pressures that your teams face today, from claim denials to payer delays to patient financing to staffing gaps. There are so many challenges. Looking at this landscape, looking at the innovation that's coming out in the market, how do you go about setting your top strategic priorities, looking forward 3 to 5 years ahead and looking in the next 10 to 12 months?
Well, you said it correctly that the pressures on the healthcare systems are greater than ever before for multiple reasons. Now the governmental pressures of Medicaid cuts and the pressures by the managed care companies and policy changes that are affecting payment and the denials and delay of payment is enormous. I think it was maybe a month ago, Kaufman Hall did a little expose on what health systems need to do in order to kind of confront these challenges. It's almost going back to the basics, going back to developing new strategies on dealing with the revenue cycle, dealing with lowering your length of stay and your operations, improving your identification of patients, whether they're admitted or they should be in observation or they should stay in ED status, and statusing patients correctly. It's looking at your workforce and how you can lower your span of control and lower your operating cost, and whether you should be replacing people as length of stay reductions. Should you adjust your workforce accordingly? All of the basic things, improving all of your outpatient areas, your wait times, reducing wait times, increasing new patient visits. All these things, it's funny because we've been on that journey for almost a year and a half now, doing all those exact things because of the pressures created predominantly by denials, but also that we knew the pressures were coming on Medicaid, and we knew that was the increased payments on provider taxes and transfer payment programs were all going to start getting weaned back. And some states in the country were at the maximum of provider taxes. We in New Jersey were not. We were just getting to a higher level. So the impact for New Jersey hospitals may not be as severe in the initial stages as other states which were at the maximum of transfer programs and provider taxes and transfer programs. So So we're kind of in the middle on that. So we're actually going to see a pickup for these supplemental programs and for the rest of 25 and into 26 before we start seeing some tail off by some of the big beautiful bill that will be hitting us. So it's kind of back to the basics of readjusting your entire organization through all of your operating indicators to maximize your office practices, your office visits that will generate admissions back to your hospital, and then having the throughput in your ORs to be more efficient, through your throughput in your emergency room to be more efficient, and to make sure that you're moving some services out to your outpatient areas so you're not clogging up the ED inappropriately. So it's all the things that you have to do from an operational standpoint, but it really, every so often you have to readdress it again because things change. You get FTE creep and you get other types of internal pressures because you have to adjust to, I'll take the revenue cycle, for instance. We've had a huge impact on over the last year and a half on denials. We're down now under 4%. And I've been to a couple of conferences recently where big health systems that are much larger than us are saying that they've gotten their denial rates down to 8 and 9%. And I'm scratching my head saying, well, you got a ways to go before you, not to say we're not the best at revenue cycle, but we were much higher as I guess the middle of 2022, when payers started to really ratchet up the denial process in a whole bunch of different categories. And we had to add staffing to our model. We had an assessment of our revenue cycle about 2 years before that, and we were hitting on all cylinders. They had only minor tweaks to it, but we had to change it all around when the denials started to really go crazy, and we had to really change our throughput of how patients come in, how we categorize them, putting resources in the ED that we hadn't done before, really improving our utilization review process, our physician advisors, improving their process and maximizing that we get every patient identified that we're going to be denied, that we actually do peer-to-peers on a 100% basis, and even on a patient accounting side, to adding resources for denials management so we can identify trends where denials are coming from so that we can redirect our resources to attack those issues.
Makes sense. And when you look at these priorities from the lens of RCM teams always tend to have a long list of priorities because there's so much to do in that area, right? But of course, every organization has to make some tough choices when they create a roadmap or a strategy for a year. Can you share an example of where you had to say no to a really good initiative in favor of something even more critical?
Well, we did have an AI recommended resource in a clinical area that was going to help patient care, but there was no return on investment. It was zero. So as a matter of fact, we just had a long conversation at our senior management team last week, specifically on the issue of identifying AI opportunities and have a collective team assess it before we even attempt to. If it doesn't have a return on investment in today's environment, I don't think you should really be going that route until you've maximized all the areas where you can. And so we have said no already on a clinical area, and we're actually instituting an AI resource in our physician office practices to help identify their problem list. I don't know if you know that when you go to see a primary care doctor, whatever, they usually, whatever your medical conditions are as identified in the electronic health record as a problem that you need to address. And every visit should address those problems. But as you're seeing lab results, interviewing patients, and AI taking over, some certain predictabilities now come to play that as a practitioner, you can head off from having a serious medical incident. So we're trialing that out now, and it looks very promising. We've also done other resources in the ED and in a similar fashion to better manage patients as they come in the door and help the practitioners do what they do best.
Makes sense. And I'm going to take a couple of points that you had mentioned in the last few minutes for my next question. You mentioned your claim denials are at 4%, which is one of the lowest in the industry. And you also mentioned you typically like to pick projects that tend to have good ROI. So looking back at the recent HFMA event a couple of months ago, utilizing Agentic AI for something like claim denial prevention, patient financing, financial assistance was all the rage at the event, right? So when you look at your own strategic priorities, where do you see something like claim denials or patient financing fitting into the strategic priorities? Is that like always an ongoing priority every year, or does it vary from one year to another?
It's always a priority, revenue cycle, because it can slip so fast. We were doing great, and suddenly our results weren't what they used to be. Going back prior to the pandemic, our denial rate was actually at 2%. So we were now we think we're doing pretty good at 4% because it's now been an avalanche of new issues coming forward by payers that we're trying to address. We have, and even on things like peer review, and we have a good team of one physician in particular, but we have others. So we have a team, we make sure that 100% of denials while patients are in-house get peer reviewed and go back to the payers. And we're right now running, we just hit our last month, our highest 80% success rate. When we started, we were only at about 35% success rate. So we've improved that. But just because we got the medical director of a payer to reverse a decision on a denial doesn't mean it got paid. We have to do, our back end people have to do the follow-up work to make sure that the payer actually reverses it in their claim adjudication system, because we're seeing at about a 10% failure to adjudicate the claim after it's been overturned, requiring us to do follow-up. Otherwise, we wouldn't get that extra 10%. We didn't know that going in, but we know it now as we started to look at a claim. So we know every case has to have a secondary follow-up if it doesn't show up as being paid.
Makes sense, Garrick. Thank you so much. With that, let's take a short break. When we come back, we're going to be discussing a very exciting initiative that Garrick and his team led for their organization that resulted in some significant outcomes. Stay tuned. We'll be back soon.
When care feels out of reach, patients walk away. Hospitals are left with denied claims and money they cannot collect. RCHQ's Agentic AI cuts claim denials and helps patients set up payment plans that fit their budget, while connecting them to assistance programs like Charity Care and Medicare. Seamlessly integrates with your existing RCM systems with no coding required. Empower patients, protect revenue, increase cash flow. RCHQ, every patient's trusted AI financial assistant.
Garrick, so let's dive right in. I'd love to dive into a recent initiative you led. We both talked to each other about it while we were at HFMA. So looking back at the initiative, let's start with what challenge were you looking to solve with this project?
So we have a significant number of patients that cross our threshold. When I say cross, mostly the emergency room, but it happens at some of our off-site and on-site clinics where patients come in with nothing, no insurance whatsoever. They're not on Charity Care, they're not on Medicaid, they're not on any type of assistance program. And so we've always had a combination of resource advisors, which are employees that go in and actually interview patients and see what they qualify for. But we only had a manual tracking process. And we have a lot of outpatient services. We run a major family health center that has internal medicine, pediatrics, and OB, where patients are coming in, and there's a lot of documentation that's needed that patients don't walk in. So we get them presumptive eligibility for Medicaid the day they walk through that threshold. And then we have usually 90 days to obtain the information, requiring patients to come back and follow up, and only a certain percentage do. And we know, because a lot of this is repeat business. We are a a Catholic organization, and our mission is to take care of all people, regardless of their ability to pay. So we never turn anybody away. We did require for a period of time a deposit towards care, of nominal amount, just to get them to come back to complete the documentation. Because if we're going to take care of them anyway, and they know that, patients aren't going to be as willing. But if you put a few bucks up front and say, okay, you'll get your deposit back as soon as you provide the information, even that was only somewhat successful. But we're using manual Excel spreadsheets, and we know we were missing a good percentage of patients. And because of things like the transfer program, the outpatient Medicaid managed care transfer program, we get additional payments outside the payment for the claim. So right now in New Jersey, for us, it's $200 extra for every outpatient encounter, regardless of what the value of the claim is, whether it's a $20 lab test or a $4,000 same-day surgery, we're going to get $200 more for the encounter. So it made a lot of sense for us to go back and really rethink the whole process and using and develop with a company an AI tool that was out in its preliminary stages. We said this thing had a lot of promise. And so we contracted with a company and now have, when our counselors, instead of screening the patients, we're educating the patients on what documentation they need to provide in an app on their phone. Most patients who are poor and are underserved populations actually have smartphones. So putting a simple app on their phone, educating them on where to get to image the documents in their house. They don't have to come back to the hospital or to our family health or any of our locations. Do it once. It auto-populates the remaining of the elements of the application and automatically files it with Medicaid, with the state with the county social services department. So it takes less touches between our staff and the patient. It gets the documents in much faster. And as with the big, beautiful bill that's out there, the time of presumptive eligibility and when it can go retroactive is going to go from 90 days to 30 days. We're already in a position where most of these applications are now done within that 30-day time frame already. We have a few more things we're thinking about to tighten up the process a little bit. But every day after that initial encounter, text messages go to the patient to remind them of the documents needed to complete. So it's a very seamless process. We increased our charity care and Medicaid identification significantly on both categories. And it's big for us. I mean, we're a safety net hospital in New Jersey. And that means that we have so 13,000 people crossing the threat. That's a lot of people that need to be screened in the course of a year. And having this automation has absolutely improved our processes. And we work with this particular vendor, and we've improved the reporting. Everything that we've suggested on how to improve the reporting they've affected. And even now it is tested the time with audits. In New Jersey, charity care, we have to bill it, and they get audited quarterly. And so we've met our quarterly audits with this tool, which makes even the auditors happy because they're coming in and they can just sit at a screen. We teach them where to go to get the information. We used to have to pull files days before they came in the door. Now we don't even pull anything. We just direct them to a computer screen. They give a sampling and says, here's how you go to get the accounts, and they do it all within a day or so, when it used to be a week or so to get the audit completed.
Exciting. You talked about working with the vendor. What was your selection criteria when looking across a pool of vendors, and how did you go about selecting a solution partner for this implementation?
Well, this was a relatively new product, and we heard about it through one of the legislators at the state level who knew us as a safety net hospital, said, this other place is trialing this out. Take a look at it. And when we did, we also checked around. Nobody was doing anything like it. Some places that have Epic, we're in the middle of installing Epic. We're not there yet. said, oh, Epic has some of these. All they really had was a portal to put a piece of information, but it didn't complete the applications. It didn't have the ability for a patient to go and do it on their app, so they don't have to come back to the hospital. It was a help, but it wasn't anywhere near the complete thought process. And we looked around. There wasn't anybody else in this field doing this exact. They would have to start from scratch. Fortunately, this particular vendor was really looking at how he could create products to help the underserved population, which is novel. When I teach at Rutgers, I also teach at the graduate level and talking about all of the different initiatives. All the major huge companies like Google and Amazon all have big health initiatives, and they're failing 9 times out of 10 with new initiatives. But they're not doing it for the underserved population. They're always doing it for the wealthy because they want a major return on their investment. This was kind of a unique vendor that was really looking at how they can help facilities that deal in the underserved population as a greater percentage of their business.
Makes sense. And looking back at the implementation, did you come across any pitfalls or surprises that you did not foresee? And how did you cross the bridge in terms of overcoming the challenge?
Well, the big thing was education, and we had to re-educate some of our staff. Like any new technology, staff is a little trepidatious about implementing it. They're not always gung-ho. They don't see the net benefit. And as a matter of fact, some of the staff felt that they could be losing their job because of it. We didn't let anybody go. Their job focus changed from screening applications to educating patients on an app and where to go to get their pieces of information. So it totally changed their job in a better way. And now follow-up time is much shorter. And there's a certain percentage of patients that really can't use the app effectively. They have education challenges and the like. And that's where they spend their extra time on the few extra patients that need some extra care in order to complete the processes for both charity care as well as Medicaid applications go.
Fantastic. With that, let's take a short break. When we come back, we're going to hear Garrick's perspective on innovation in the industry and how does the new innovative technologies apply to the area of revenue cycle. Stay tuned.
1 in 5 hospital claims is denied. Behind every denial is a patient delaying care and a provider losing cash. With RCHQ's Agentic AI, fewer denials mean faster reimbursement. Patients get payment plans that fit their budget and access to programs like charity care and Medicare. No coding required to make RCHQ work with systems you already use. With RCHQ, you see an instant increase in cash flow.
Great. So let's shift gears into the area of technology and innovation. We heard a lot about Agentic AI at HFMA. What role do you see Agentic AI playing in the revenue cycle area in this year, as well as looking ahead 3 to 4 years?
So there's probably not a single component of the revenue cycle that couldn't have an AI initiative to improve the operations. Before we started on Epic, we were looking at using bots for the pre-registration and specifically on insurance verification work. And we were starting down that path, but because of the Epic install, it was going to probably confuse the staff, even though post-Epic, we're going to go and finish that project. And not to let people go, but to automate the process so we get all encounters, not just the ones that have high dollar value, like admissions and same-day surgeries and certain high-end outpatient procedures, but across the gamut. We don't have the staff to insurance verify everybody for everything, but with bots, we can expand the field quite a bit to make things much easier for our staff, and then redeploy that staff in other areas. because we don't look to, we're going to lose people. We're going to have to retrain them in other areas. But I can see my next area after that is to look at, so we say we're doing pretty good at just under a 4% denial rate. I still want to use AI technology to be able to predict where payers are changing their patterns faster than we could do by looking retroactively over time at claim and claim development. I believe AI can do that much faster and more efficiently so that, because it's like a game of tennis. The payer creates a policy that now creates a problem for us. We need to create some sort of solution that addresses that problem so it doesn't continue on us. And it's just this back and forth. And one of the big hidden things that have happened with payers across the country is they're constantly making policy changes that affect the ability to get paid and slowing down the payment cycle. And that's requiring more resources on our, but if we can predict it faster, we can get the solutions in place faster. Yeah. I think one of the other things that's happening right now is the state of New Jersey, through the New Jersey Hospital Association, has gotten with a vendor to take statewide data, the 835 transaction files, which come with payment and denial information to all the hospitals, to aggregate that on a statewide basis so that we can see patterns and trends comparing hospitals may not having the same problem with the same payer or may have the same problem, and gives us the insight to start going at a different level, which is in the long term, going after legislative solutions and regulatory solutions to the payers. And the reason why this is really important is because in New Jersey, the Department of Banking and Insurance, which regulates managed care companies, can only regulate the risk product, which is the products that are insured, the HMO products. But most of this insurance business, insuring health, is on the commercial side, is self-insured health plans. Only the small businesses, 50 to 500 employees, are still heavily in the HMO market. Anybody that's larger than that has gone self-insured a long time ago. So about 70% of the business of commercial insurance is really self-insured employers using the major players as third-party administrators and network access for claim management.
Interesting. We talked a lot about insurance verification and addressing claim denials using Agentic AI. Outside of Agentic AI, are there other up-and-coming technologies in the market that you find exciting and you see a lot of potential in your organization?
Well, there's two things. I've seen some interesting things, but not tested. And what I'm really afraid of is the name of that company a few years ago, I think it was Theron, that had this lab testing equipment that was going to revolutionize lab testing and improve lab results. It turned out to be an absolute fraud. The head of the company went to jail. And interestingly enough, there were many big-time name investors in that company that got totally embarrassed. I think Amazon was in there. There was a few other some of the big names that are out across the country and lecturers on healthcare and futurists were investors in that company, and they all got snowed. They all got taken by what seemed like a nice shiny object that was going to everyone loved the idea of what it could do, but no one spent the time to kick the tires on the actual product to show that it could actually do what it claimed it could do, and it never did it. So there's a lot of snake oil out there as well as a lot of good products. And so having to test those well before you implement them is really key.
I'm guessing you're referring to Theranos, by the way.
That's right. I couldn't get the name correct. You're right.
Makes sense. Looking at finance and RCM, is there one metric you obsess over every day and you look at first thing in the morning?
I'll look at a couple of them. I mean, we have our days in AR. We have the classic metrics that we look at. But we get into the details now to look at claims that are out there for extended periods of time, not because of the fact that it's a denial, but because of the fact it's not getting paid. We just settled with a major insurance company back in, I think, February of 2025 for over $3 million of claims that were 2 years old and prior that had no basis for not being paid. Now, the value was greater than that, but it was at a point there was one payer that actually refused to adjudicate the claim. So we never even got a denial. Now, this is a patient, this was on a NICU baby. It was about a $750,000 claim. And there was 2 insurances involved because the patient changed insurers in the middle of the stay. And so the first payer had to get either a denial or a payment so I could get the second payer to pay. That first payer wouldn't adjudicate the claim for 3 years.
Wow.
A self-insured claim. I had no basis to go to any sort of regulatory body to complain about it because it was a self-insured claim. This is the sort of egregious practices that are going on now that unless you're on time, and we don't give up on anything. Some of the big systems I know, after 180 days, they give all their accounts out to someone else. And I guarantee you they wouldn't follow up unless we follow up on we know every claim that's outstanding that should be paid, that has no justification for non-payment, and we follow up. Other vendors would give it a period of time and then probably drop it off. To go as long as we've had claims that are paid after 4 years. That's how far back some of these egregious practices go. But unless you're on top of it on a regular basis. So we look at each payer and look at the outstanding old claims and bring that to the fore with meetings with the payer. And it can't be at the staff level. They can handle the day-to-day transactions and things that we have representatives from the payers. They'll handle but sometimes it's the big claims that we need to have senior executives on both our side and the payer side to get the attention it needs to get paid. And unless you're doing that, you're not going to get resolution.
That makes sense. With that, let's take a short break. Stay tuned. We'll be back soon.
Every denied claim is money left on the table. Every missed payment is cash flow you may never see again. RCHQ utilizes Agentic AI to lower denials, set up families with affordable payment plans, and connect patients to affordability assistance programs like charity care, lower denials, expand affordability, and strengthen cash flow. RCHQ makes it possible with no coding required. Visit rchq.com today.
Great. Garrick, when you're executing projects of this scale, change management is really hard, especially in complex RCM environments such as yours. How do you build momentum for change across your teams? How do you bring people together to successfully execute these projects?
Well, a couple of things. One, you need to bring all the payers, all the employees involved in all the different areas together to start with. And secondly, you have to, I think Stephen Covey, he wrote the book, 7 Habits of Highly Effective People. Begin with the end in mind. What's the outcome you're trying to achieve? And get that group of people that will be affected by that project. And in the case of revenue cycle, it goes pretty wide. You need to get a lot of the clinical buy-in to go along with what you're trying to achieve and get them to buy into the solution. And if you don't have that, you're going to have a very tough road to hoe. And let it be known up front. Don't sugarcoat it. If you know you're going to have disruption along the way, which most projects do, be open and candid about it, as opposed to just let it fly and then deal with it as it happens, because that's not a good way to handle it. You may not know all of the interruptions that will take place on it, but anything you do know from other places that have implemented something, make sure everybody knows what those interruptions will be, and you'll have a better outcome, and people will be understanding. It's what they don't know that hits them that people get upset. But if they do know, and most people want change. People say you don't want change or whatever. Most people don't want to change what their behaviors, what they're doing now, but they all want change. And I can prove that easily. Just look by how many people buy lottery tickets. They're looking for a change. They're looking for that big payday, and they're looking for that because they do want change. It's a positive change. So you have to make sure that any changes you're bringing to the organization, you have to bring the positives out so that you can get the buy-in to get them to work, people work effectively to make the change happen. I've done a number of projects internally here over the years that had a lot of headache to it, a lot of gnashing of teeth and people getting at loggerheads, but keeping the end in mind and keeping arresting people's fears. Today, because of technology, the big fear is I'm going to lose my job. And you've got to make sure that that's not the reason why you're doing what you're trying to do.
Yeah, that makes sense. If there is one piece of advice that you could give to another RCM leader or a CFO who's potentially tackling similar challenges in other organizations, what would it be?
I think sometimes you need an independent look. You get too close to the internal operations and the people, and you've got to take personalities and people out of the equation and look at raw processes. Some people can do that well within their organization, and sometimes you need an outside independent look to make that happen. So it varies among organizations. We have some really good critical thinking people here internally that can look at aspects to it. But even then, sometimes an outside perspective gives you that extra insight that you don't see in the process. And with revenue cycle today, everything has to change because the payers are making us change every day.
That makes sense. One last question. Could you tell me about a recent book, a podcast, a framework, or even a TV show that has significantly influenced your leadership thinking when you approach RCM and finance in healthcare?
Well, it's talking about a TV show. You just hit me on one aspect. When I start my class at Rutgers every semester, I get a little background on myself, and I answer the question I get asked the most: what keeps the CFO up at night? And I show them a piece of technology, a little device, and I ask if anybody knows it. Only once in 10 years has anybody ever guessed what the device is. It's a tricorder from a 1960s TV show called Star Trek. And Star Trek had a device for the medical officer that would actually do most of the diagnostic testing that you could do in an emergency room. It would do lab work, x-rays, different types of scans, all types of testing that would be done for all the different ancillary departments that you have. And people say, well, what difference is that? That's science fiction. Well, and why would that be important? I said, if you had that device, first off, most of your emergency room visits would go away because they could be done in primary care offices and urgent clinics, and they would basically wipe out. And don't think for a second that hospitals and health systems aren't making a huge amount of money on their emergency room visits. They are. It used to be thought of as lost leaders. Not anymore. I don't know anybody that loses money on an emergency room, but that dynamic change could be enormous. And so a follow-up question is, well, that's science fiction. Well, maybe not. There's a company on the West Coast called Qualcomm that put $20 million up for inventor that could invent most of the elements of what a tricorder does. So it's not that far off. And so, what really keeps me up at night and what keeps me worried is the technology that can actually radically change our business model. And it will come. And probably within the next 10 years, it will come. It will come in degrees, but it will come nonetheless. And thinking about our business model and how we have to change because of it is what drives me all the time. And so I'm reading up on technologies all the time to try and see where is it heading, and where is it going to have the real impact on our business model. Right now, it's had minor impacts on the business model. The major ones are on the way.
Makes sense. Garrick, thank you for sharing a lot of insights in our conversation today. I know our podcast listeners walk away with plenty to think about. And of course, today's conversation, focusing on RCM, focusing on technology, there were a lot of takeaways. So thank you so much.
You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle.